I'm Raj Makkar from Cedars-Sinai Medical Center in Los Angeles. So let me first talk about the ACURATE IDE. It's a randomized, multi-center, non-inferiority trial where we randomized 1,500 patients to either the ACURATE Neo2 valve versus the control valves. And the control valves consisted of the SAPIEN and the Evolute valves. And what we found was that we were not able to meet the non-inferiority endpoint. So ACURATE Neo2 was not inferior to the commercial valves. So we set out to find out the cause for worse clinical performance of the ACURATE Neo2 valve. And one of the things that stood out during the review of cases was that some of these valves fluoroscopically did not look well expanded. So the investigation basically that we undertook was to investigate fluoroscopic appearance of all of these valves using a core laboratory. Well, as we know, all self-expanding valves could be more prone to more under-expansion compared to balloon expandable valves, though we now know that even with balloon expandable valves, there can be under-expansion and eccentricity in the way they actually are deployed. But the ACURATE Neo2 does have less metal and less opening force, which might make it a little bit more prone to this phenomenon. So once again, it was patients with severe symptomatic aortic stenosis that were enrolled in the ACURATE IDE. So essentially all patients that we are talking about are patients who have severe aortic stenosis. And for the purpose of this analysis, the under-expansion analysis, we focused only on the ACURATE Neo2 valve. So about 750 patients who got the ACURATE Neo2 valve, we studied under-expansion in these patients. We developed a methodology. So the ACURATE Neo2 valve has 3 posts. And when the valve is well expanded, these posts would appear parallel fluoroscopically. If these posts are not parallel, and if you were to draw a line, and if they were to actually intersect these lines through the post in what is called a pre-specified boundary, then the valve was considered to be not well expanded. And we validated this on a benchtop. We validated this in patients who had follow-up CTs. So this was something that was validated to some extent. And what we found was, using a core lab analysis, that this phenomenon occurred almost 22% of the time. So essentially 1 out of 5 times we found that the valve was not properly expanded. And it became important for us to understand, what is it that actually causes, what are the factors that are associated with this underexpansion, and what is the impact on clinical outcomes. So what we found was there were no clinical characteristics, in terms of echo characteristics, underexpanded valves, were more often a little bit tighter compared to expanded. These are patients who had larger annuli, and most importantly, more calcific aortic stenosis was associated with underexpansion. Indeed, in a multivariable analysis, that was the only thing that actually stood out. It wasn't differences in the pre-dilatation or post-dilatation. Now, agreed, perhaps we were less aggressive, though we pre-dilated the valve almost 100% of the times, and the average balloon size was 22 millimeters, but perhaps we may have been a little bit less aggressive in pre-dilatation overall in the trial compared to what some of our European counterparts actually do. We also post-dilated a quarter of a times, but this was not different between the expanded valves and under-expanded valves. This also is a little bit less frequent compared to our European counterparts, where post-dilatation is done a little bit more, maybe around 35-40% of the times. One of the things that we observed was that under-expansion was associated with worse clinical outcomes. So the primary endpoint of death or stroke or rehospitalisation occurred more frequently, almost 19% of the times compared to 12% of the times, which was the case in well-expanded valves. And then also, if you look at just death or stroke, even that was significantly different, almost 13.5% compared to 7% with the well-expanded valves. So clearly there is an association. Now, we did try to figure out, so what is it about under-expansion? All right, so theoretically under-expansion can cause worse hemodynamics, it can cause more PV leak, and it can cause more thrombosis. So we looked at all of those things. We didn't see a difference in gradients or valve areas, but the DVI, Doppler Velocity Index, which is agnostic of the size, and because these are patients and cohorts with different size valves. So the DVI was actually lower in patients who had under-expanded valves. So that's some evidence of worse hemodynamics. We did, once again, notice a trend towards higher leakage, paravalvular leakage in patients who had, under-expanded valves. So with those things in mind, I think what we want to do is, what we know is that this under-expansion is something that can be rectified by better predilatation. Also, in our analysis, what we found was that half of the times, if you post-dilated, you could make the under-expansion better. It's also important to point out that not all under-expansion was present, or not all post-dilatation was done in patients who had under-expanded valves. So clinically so far, the way we are programmed in the cath lab is to post-dilate these valves if you see less than ideal hemodynamics or some leakage. I think what we're bringing spotlight onto is, besides those two things, it's also important to look at fluoroscopy. And if on fluoroscopy, if the valve looks under-expanded, and if you can safely expand it by post-dilating, then it should be done. We still have to prove, whether this will actually result in better outcomes. What we know is that under-expansion is associated with worse outcomes, and what we know is that to some extent you can rectify under-expansion with balloon inflation, but will it make an impact on clinical outcomes yet needs to be shown. Well, I think for clinical practice, it means that I think what we're looking at both. We are looking at device iteration, which makes the device have more opening force. And that has already been done. The ACURATE Neo2 valve has now transitioned to the ACURATE Prime valve, which is characterized by somewhat more radial force or opening force. Also, I think the other important thing that it means for clinical practice is that when you're using this valve, you must pay attention to adequate expansion, and that can be done with good predilatation by looking at the valve in two different views so that you can diagnose this. Okay? Be conscious about the fact that if the valve posts are not parallel, you can use post-dilatation and you can try to optimize to the extent you can without causing aortic root injury or excess conduction system issues. So I think it's always a balance. So we want to actually, and perhaps avoiding this valve in patients who have very calcified anatomy. So I think those are some of the things I would actually keep in mind. I think that more data, clinical data are being presented on ACURATE Prime. In fact, at this meeting at the EuroPCR, and the results actually look excellent. But once again, it remains to be seen whether now we will have another randomized clinical trial, with the ACURATE Prime, comparing it to control valves, and of course, being mindful of this under-expansion issue and how to rectify it by modifying the procedure with good valve preparation and good valve post-dilatation.